Bismillah ar-Rahman ar-Rahim. Our topic today is systemic sclerosis. Systemic sclerosis, also called scleroderma. As systemic sclerosis, here we have a chronic systemic, it is a chronic systemic disorder of unknown etiology, characterized by thickening and fibrosis of the skin. This is called scleroderma. And multiple internal organs involvement, mostly lungs, GI tract, heart and kidneys. The progressive visceral organ dysfunction are due to fibrosis. The presence of a thickened fibrosis of the skin is called scleroderma. This distinguishes systemic sclerosis from other connective tissue diseases. Systemic scleroderma might be limited. The cutaneous scleroderma might be limited cutaneous systemic sclerosis, or it might be diffuse cutaneous systemic sclerosis. The clinical features are, on the top of them is Raynaud's phenomenon. Raynaud's phenomenon, almost it is present on almost most of the patients. Almost about 98% of patients. Raynaud's phenomenon. Skin induration and calcinosis. Esophageal dysmotility, sclerodactyly, telangiectasia. We have a syndrome called CREST. CREST 5 حروف CREST. CREST. C. calcinosis. R. Raynaud's. E. esophagitis. S. sclerodactyly. And T. telangiectasia. Systemic sclerosis might be localized to skin and in such a condition it is of a better prognosis, or it might be generalized, involving skin and internal organs. But it is said that silicone breast implantation, silicone exposure, vinyl chloride chemicals exposure might play a role in the causation of the disease. Now the clinical features. The skin features are thickening, dry skin, taut and shiny skin. We have microstomia, small mouth, beak-like nose, telangiectasia, calcium deposition in the skin and subcutaneous tissues, buckling of mouth. Now the GI tract involvement in 90% of cases, esophagus, stomach, small intestine, gastroesophageal reflux, esophagitis, and may lead to stricture and gastroparesis. Pulmonary features in systemic sclerosis. It is the leading cause of death. It might be asymptomatic, slowly progressive, exertional dyspnea, interstitial lung disease, fibrosis, pulmonary artery hypertension, renal involvement may lead to hypertension, and also it is one of the causes of death. Musculoskeletal features in systemic sclerosis. We have arthralgia, we may have CTS, carpal tunnel syndrome, joint stiffness, and restriction of movement. Sometimes we may see cases of shoulder stiffness, frozen shoulder, due to systemic sclerosis. Tendons, leathery crepitations. A treatment of systemic sclerosis, scleroderma. For the skin care is important. For scleroderma, renal crisis is considered to be a medical emergency. Usually it is treated with AC inhibitors, يعني angiotensin converting enzymes inhibitors, non-steroids and steroids. Treatment of pulmonary arterial hypertension, it occurs by diuretics and oral anticoagulant. For gastroesophageal reflux, full dose of PPI, proton pump inhibitor. Immunosuppressive and others, disease-modifying antirheumatic drugs. Are of some benefit. It is said by Hughes, one of the famous rheumatologists. He said, he have a statement, no drug is said to be useless unless it is used in the treatment of systemic sclerosis. Actually, this statement reflects the failure of treatment in systemic sclerosis for the severe cases. Now another topic. Here the skin involvement on the left side and the microstomia and telangiectasia on the right side. Case of systemic sclerosis. Now another topic. Polymyositis and dermatomyositis. The in polymyositis, here we have an inflammatory. Polymyositis is an inflammatory disease of skeletal muscle. If it is associated with the skin involvement, it is called dermatomyositis. So if the skin and muscles are involved, it is called dermatomyositis. If only the muscles are involved, it is called polymyositis, skeletal muscles. Polymyositis can occur in isolation or in association with other connective tissue diseases, as SLE, systemic sclerosis, is Sjogren's syndrome, or it might be a feature of a hidden malignancy. So polymyositis might be a feature of a hidden malignancy. The clinical features of polymyositis, here we have proximal muscles weakness in upper and lower limbs, difficulty in raising from a chair, climbing stairs and lifting, later muscle wasting and contractures, calcinosis in muscles. So muscle weakness is a marker of disease activity. In dermatomyositis, in addition to skeletal muscle features, we have skin lesions, including gutterance papules on the proximal and distal interphalangeal joints, violaceous papules in the proximal and distal interphalangeal joints. Also, you may have a heliotrope violaceous discoloration, heliotrope violaceous discoloration of the eyelid with periorbital eye edema. Similar violaceous rash and shawl distribution in upper back, chest and shoulders. shawl distribution يعني يسموه شال. The regions in which they put the shawl, there is an increased risk of associated malignancies, which should be searched for. So one should search for a hidden malignancy if we are facing a case of polymyositis. Investigations are by muscle enzymes, creatinine phosphokinase, EMG to confirm the myopathy and to exclude the neuropathy, and by muscle biopsy. A treatment of polymyositis is by corticosteroid, high dose systemic corticosteroid, up to 1 milligram per kilogram daily, that's to say about 60 milligram daily, till normalization of the enzymes. Then one may taper the dose. Sometimes one may add immunosuppressive drugs. Physiotherapy has an important role for restoring muscle strength and joints range of movements. Another topic is Sjogren's syndrome. Sjogren's syndrome is the syndrome of dryness. Here we have a combination of keratoconjunctivitis sicca, that's to say dry eyes, xerostomia, a dry mouth, and a connective tissue disorder, mostly rheumatoid arthritis. If the eye and mouth manifestations are present without any other connective tissue, this is called Sicca syndrome. It is an autoimmune disorder of unknown cause, characterized by lymphocytic infiltration, of salivary and lacrimal glands and other exocrine glands. Female to male is 9 to 1. Typical age of onset is 40 to 50, 40 إلى 50 سنة. We have a chronic lymphocytic infiltration of salivary glands, lacrimal glands, and other exocrine glands, and respiratory tract, GI tract, skin, and vagina. The disease might be primary or secondary to other autoimmune disorders. Now, clinical features of Sjogren's syndrome. Eyes and the eye, ophthalmological features. The main symptoms are a great length and soreness of the eyes due to reduction of lacrimal secretions, leading to conjunctivitis and later to corneal erosions. Now, GI tract features. A dryness of the mouth may lead to difficulty of swallowing. Respiratory tract. Decreased secretion of the mucus glands in the nose, pharynx, larynx, and bronchial mucosa, so pharyngeal irritation and sometimes sinusitis, laryngitis, and increased liability to chest infections. In the genital tract, we have vaginal dryness may lead to atrophic vaginitis and secondary fungal infections. Other features: lymphadenopathy, splenomegaly, and peripheral neuropathy. About 1/3 of cases, about 30% of cases are primary Sicca syndrome. 50% of Sjogren associated with rheumatoid. 20% of Sjogren syndrome associated with other autoimmune disease as systemic sclerosis, polymyositis, SLE, etc. Now, to confirm the diagnosis of Sjogren syndrome, to confirm the diagnosis of keratoconjunctivitis sicca, one uses Schirmer's test. Here we use a filter paper sheet inserted into the conjunctival sac in the eye, and it is left for 5 minutes. If wetting is more than 6 millimeters, it is normal. If it is less than 5 millimeters, here it diagnoses the condition of dryness, يعني keratoconjunctivitis sicca. Now, the management of Sjogren syndrome. For keratoconjunctivitis sicca, one have to use artificial tears، يعني دموع هم مشتغل، in the form of methylcellulose eye drops, frequently used to keep the eye moist. So one have to use artificial tears. For xerostomia, frequent water taking, drinking, and to control local infection of candida in the mouth. Now, another topic is a mixed connective tissue disease, mixed or undifferentiated autoimmune connective tissue disease. Here we have an overlapped connective tissue disease with features of SLE, scleroderma, and myositis. There is no clear diagnosis and there is an overlapping features. In such a case, most of the patients are positive to anti-ribonucleoprotein, RNP, antibodies.